Good morning, and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
Doing quite well. Thank you, Katie.
Dr. Robert Murphy is the executive director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, public health, or infectious disease questions each week here on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be addressing the latest headlines and US COVID statistics through today, April 11th. We invite you to submit your questions down below via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Starting with the updated US COVID statistics. Average new hospitalizations per day, 1,352. In 2023, the same week, we saw 2,460 new hospitalizations per day. Average COVID deaths per day, 88. In 2023, 238. New vaccine uptake for adults, 22.6%, those 65 plus, 42.1%, and 14% in children. Dr. Murphy, your reactions to those numbers?
Well, it's absolutely as predicted that at the end of the respiratory infectious season, which is right now, the numbers will be coming down. And that's certainly what's happening. We have the average number of deaths per day from COVID, less than 100. So this is in the order of magnitude of what flu causes year round, but flu only happens also at this particular time. So this is kind of the end of the flu season, RSV and COVID. COVID went down the fastest in the season. So that's good, but that's completely expected. And the question is, when is the next bump?
Mm-hmm.
I think it's just a matter of time. COVID is not going away. The vaccine uptake, of course, is very mediocre. And we could do a lot better with that. But and we're seeing an increase in flu vaccines and RSV vaccines, but we still have a way to go. But we're at the end, in the last stage of the winter respiratory infection season.
Mm-hmm. Now, our first story today is about COVID, though it has been going down. This story about long COVID was super interesting and very insightful, adding to the body of evidence around long COVID. Can you tell us what the study was and what they found?
Yeah, this is a very good study from the UK. 657 previously hospitalized COVID patients, so they had been really sick. 426 of them got long COVID, 233 did not. And they looked at their blood samples to see what's the difference between the ones that got COVID and the ones that didn't get long COVID and the ones that did get long COVID. And so what they found was the immune system is, of course, very complicated. And there's a part of it called the complement system. It's just one of the components. The immune system is multifaceted and whatever. And the complement system was overactive in the patients who had long COVID. Now, this is also seen in other immunologic conditions that are associated with inflammation. So it makes sense. And matter of fact, it kind of opens the door, like, why are people having all these other immunologic long-term conditions? What triggered those people to have these overactive immune systems? And maybe it can lead to some better treatments. It's certainly going to lead to a better understanding. So this is a very good group of investigators. Nature Immunology is the journal that this article is published in, which is a very highly respected immunology journal. So it's just every day we're going to learn more and more about COVID and long COVID, and all this is going to translate hopefully into better prevention and treatment. Still, the best thing is not to get it.
Absolutely, still the best thing. Switching gears a little bit though to measles. We didn't talk about it last week, but of course there has been some updates in the US measles cases. Can you fill us in on those?
Yeah, measles is not going away. So measles, now there's 113 cases reported by 18 states. New York just got added to the list. There have been 7 outbreaks, which includes infections, 3 or more people getting infected. And most of the infections are outbreak related. In 2023, last year, there was only 58 cases. So you can see there's a big jump in the number of cases. And almost all of these, 83% were unvaccinated. That was 83%, 12% only had 1 dose of the vaccine. And there were 5 cases in people that had both doses of the vaccine, which is a little bit unusual. But if you look at the number of people that get sick, it's the unvaccinated ones. And most of the people with the cases are under 5 years old, over 50%. So in Illinois here, 60 of the 61 cases are in Chicago. We've talked about that part of the pandemic. Still vaccines work really well. It's an old vaccine. It's been out there forever. It's been studied. It's safe. It's quite effective. Even 1 dose gives you 93% protection, and the 2 bumps it up to 97, 98%. And that's all you need. You just need those 2. Then you don't need any more boosters for the rest of your life. So the people really at risk, keep in mind, unvaccinated or only had 1 dose, and young kids.
Mhm. Next, we have an update on our title story from last week, which was H5N1, the avian flu. Can you provide us any updates on what's going on in the US, but also on a global scale?
Yeah, this is being looked at very closely. This is a worldwide phenomenon. The United States has spent over $500 million culling avian infected poultry flocks, chickens and whatever, turkeys, because it's devastating to the poultry, but it's really devastating to the industry. What's happened worldwide, we still only have the 2 cases in the United States. Both of them had been working with cows. So what's happening is the avian flu is spreading to other animals besides themselves. Why this is happening? Well, birds come in contact with cows, but also there was an article recently about how some cattle feed is enriched with the calories that come from components of bird droppings and bird parts and whatever, and maybe that has increased the infection rate there. But they also just come in contact with birds as well. So, but in any case, more species are getting it, and we have the 2 humans that got it that were working with cows. They have recovered from their infection supposedly, or they have not died anyway. And then in Vietnam, they've noticed some more cases. They have 5 human cases there, excuse me, and 1 of them did die. And those cases had been working with birds. So it's being looked at very closely, because the good thing is, right today, humans don't transmit bird flu to another human. They're just getting it from the birds or the cows. This is good that the humans are not transmitting it like they transmit all the other flu. So if that mutates to the point where it can't transmit, we're in a lot of trouble, because this H5N1 has a much higher mortality rate. And that's why everybody is so kind of walking on eggshells, I hate to say it, but they're really watching it very closely. So far so good. We could make a vaccine for this pretty easily, like we did with the COVID. I mean, that could be ramped up pretty quickly, but of course then people would have to take it. But I think with a mortality rate of somewhere between 20 and 50%, I think people would line up for this one. but it's, it still takes months to get that going, and everyone's going to be watching this to see if this thing is going to mutate and spread and take over the flu that's going around the world. Now, we don't know how this will compete with the other flus. So, there's a lot of ifs in there, but it's got to be watched very closely.
Yeah, and specifically on your point of animal to human versus human to human transition, when the virus transfers from an animal to a human, does the more times that happen, does that give the virus more opportunity to mutate and become more susceptible to that, or how does that really work?
It's just more likely to happen. It's just, the more interaction, the more you're going to find a virus that mutates, that be easier transmissible human to human. It just makes it more likely to happen.
Mm-hmm. Okay, so we will keep our eyes on that one. Next is Mpox. Unfortunately, we've been talking about this a little bit more lately as cases have started to pop up again, both here in the US and worldwide. Can you tell us about the cases here and abroad?
Yeah, so Congo, the Democratic Republic of the Congo, where Mpox has been for a long time and had always reported animal demand transmission with a mortality rate of 10%. A lot of that comes from there, as well as West Africa. They have 4,500 cases so far this year. So that's a big jump up. So, what is going on with that? Here, the number of cases are twice as high as they were compared to last year at this particular time. Now, why is this happening? We have a vaccine that's actually effective. It was a ready-to-go vaccine, and they've ramped up production, and it's offered to people at risk for getting Mpox. And but the uptake in that population is only 25%. So here we have an effective vaccine. We have a disease that it is potentially life-threatening, but it's more debilitating than life-threatening at this point. But if the uptake is so low, one of the problems with the Mpox is getting the people diagnosed, and but as well as trying to get the people at risk vaccinated. There's so much stigma involved with who's at risk for Mpox. That a lot of people are afraid to get tested for it. They won't go in to get tested. So actually, just within the last 24 hours, a test was or test kit was approved by the FDA, and you can now test yourself at home. You have to mail the kit into the laboratory to get done, but you can do it all like yourself. You don't even have to go to a clinic or anything like that. So that's an advantage if you don't want to go to a doctor to get tested for Mpox. So that's a step in the right direction.
Mm-hmm. Definitely a step in the right direction, and hopefully will help cut down that stigma for those patients. Unfortunately, another disease that has a lot of stigma surrounding it is syphilis, which
Right.
we are seeing skyrocket in the past few years. Can you give us an update on that, and also touch on congenital syphilis? Excuse my pronunciation.
Yeah. Yeah, so syphilis was almost eradicated in the United States, and that was due to a massive screening program, because syphilis was just, a lot of people had syphilis. And in the 50s and 60s, like when you got admitted to a hospital, you had a syphilis test. When you went to your annual physical exam, always had a syphilis test. You got married, the marriage blood test was a syphilis test. So people were getting tested all the time. What happened is it worked. Like there was no syphilis. And so all they were finding in the, I guess it was the late 60s, early 70s, whatever, was that they were only finding false positive syphilis tests, because all the true positives said there weren't any true positives, or there were very few. So the syphilis testing ended up causing more problems than helping after a while, when we got rid of the infection, so they stopped doing it. So guess what? It's come back in a big way. US syphilis rates have increased 80% In 2022, there were 207,000 cases of primary and secondary syphilis and 3,700 cases of congenital syphilis. That's a baby who gets infected in utero while the mother's pregnant and, gets syphilis as a fetus, and those babies, it can be very, very sick and it can even kill them. So that's a big increase in the number of cases. So from 2018 to 2022, the congenital syphilis cases increased 183%. And the syphilis cases, the regular syphilis cases by 80%. On top of this, what that's led to is a shortage of benzathine penicillin. That's the type of penicillin the best used to treat syphilis. So there's a shortage of that now. So all that it's really terrible. If you look at the congenital cases, which is really sad, 90% of them would have been treated successfully if they'd been identified during the pregnancy. And what's happening is 40% of these babies born with the syphilis were with mothers who didn't receive any care during their pregnancy. Now, how can a pregnant woman not have any care during their pregnancy? I mean, this is like a tragedy. It's really quite sad because, if it's identified early, it can be treated and those babies can be safe. So it's just another kind of fault in this kind of haphazard, disjointed public health system that we have today that is run individually by states, by cities, by counties, by the territories. It's just such a hodgepodge and it doesn't work. It doesn't work well.
It's creating unnecessary barriers to entry for some of these patients who do need the care.
Right, exactly. So, this is public health and, this is the price we pay for having a system. Now, this is not just a US problem. Other countries have the problem, but they attack it in a very different way, more coordinated.
Mm-hmm. Well, unfortunately, not a very happy note to end on, but yes, and any thanks. I would like to thank you, Dr. Murphy, very much for breaking down these articles, answering our questions, and also going through the COVID statistics. It's much appreciated.
Great. All right.
And thank you all for joining us. If you have any questions, please feel free to leave them down in the comments below or at any of our social medias linked in the description. Thank you so much and have a great weekend.
Have a great weekend.